and welcome back to the ACRO podcast, CURiE Conversations. I'm Dr. Veronia Fahmy, a member of the ACRO's CURiE team and a radiation oncology resident at Loyola University Medical Center in Chicago, Illinois, and I'll be your host for today's episode. Today, we're discussing one of CURiE's recently published articles, Definitive Radiation in Serous Carcinoma of Unknown Primary with Isolated Nodal Disease, a case review. I'm joined by the lead author, a fourth-year medical student, Nneoma Uzoukwu, and senior author and PI of the project, Dr. Jeremy Price from Temple University in Philadelphia. Thank you both for joining us. To start, could you briefly introduce yourselves and tell us about your current roles and clinical interests?
Yeah, so my name is Nneoma Uzoukwu. So I'm a medical student at the Lewis Katz School of Medicine at Temple University, and I'm currently a fourth year medical student applying OBGYN.
My name is Jeremy Price, an associate professor, residency program director, and med student clerkship director at Fox Chase Cancer Center and Temple University Lewis Katz School of Medicine. And
Great.
clinically, I do a lot of GYN, and that's part of how this project came about.
Great to have you both. Thank you so much for joining.
Thank
So
you.
could you briefly tell us a little bit about the case for some background for our listeners here? High-grade serous carcinoma most commonly arises from the ovary, fallopian tube, endometrium, or the peritoneum. And in rare cases, however, no primary site can be identified. And in your report, you tell us about an 88-year-old female that presented with an isolated pelvic and inguinal nodal disease from a Mullerian high-grade serous carcinoma without a detectable primary tumor. And following progression on endocrine therapy, she underwent definitive radiation and achieved durable disease for more than 30 months. So could you tell us what motivated you to publish this case and what are some of the key findings that you were able to find from your research?
Yeah, so what really motivated us to publish this case was the combination of the fact that the rarity of the presentation, the treatment approach, and the durability of the response of the radiotherapy that we had did. So high grade serous carcinoma typically presents with adnexal uterine peritoneal or disseminated disease, and this patient it was isolated to the inguinal and pelvic lymph nodes with no identifiable primary, which is very uncommon. So the other striking part that motivated us to publish this case was the fact that this was an elderly lady with a significant cardiac comorbidity. So the standard approaches like surgery or chemotherapy were not ideal. So despite that, our treatment approach, the definitive radiotherapy, led to a normalization of her CA125 levels and also durable disease control for more than 30 months. So this case highlights a rare disease biology, but also potential meaningful treatment option for medically frail patients um who don't can't get surgery.
Yeah, and the few case reports that do exist for this really do just focus on chemo and surgery. So this was the first, I think, that really focused on radiation.
Great, thanks for sharing that. And one of the most interesting aspects of the case was actually the diagnostic workup. So, could you walk us through how the diagnosis of Mullerian high-grade serous carcinoma was established, despite the absence of an identifiable primary tumor?
hmm So we diagnosed this case through a combination of imaging, pathology, and immunohistochemistry, and also excluding other primary sites. So clinically, as I said, she had a large left inguinal mass, which showed a left lymph node. And as well as left pelvic sidewall lymph nodes, but no primary. So the core biopsy that was taken showed high grade serous carcinoma. Immunohistochemistry supported a Mullerian origin. The tumor was positive for CK7, PAX8, WT1, P53, P16, and estrogen receptors. So PAX8 and WT1 were exceptionally important in supporting a Mullerian serous differentiation. And the tumor was negative for CK20, CDX, and TTF1, which helped argue against a GI or lung primary. So though no primary lesion was identified, the pathology strongly supported towards a Mullerian high-grade serous carcinoma presenting as a nodal-only disease. And also this was also a diagnosis of exclusion. We attempted endometrial biopsy as well, and she had imaging which showed no other sites.
In a perfect world, you would surgically stage these patients, but she was not able to get that type of surgery.
Yeah, great. Hopefully, no one asks you to say all these molecular identifiers in a residency interview. Great. And as you had mentioned, given the patient's age and comorbidities, treatment selection was very important to the success of this treatment and durability. So, but what kind of caught my attention was the selection of the initial endocrine therapy. So, what ultimately led that initial selection, and ultimately for the selection of definitive radiotherapy?
So for this patient, so endocrine therapy is usually not frontline standard therapy for high-grade serous carcinoma. However, there was some evidence that we talked about in the papers that suggested potential benefit in ER-positive cases, especially when patients are poor candidates for chemotherapy. So in this case, we there was this approach was offered due to the fact that it was a lower toxicity initial approach. However, she was on endocrine therapy and her CA 125 levels increased and imaging showed enlargement of her mass. So therefore, the first surgery because again, she was very frail and she had her cardiac comorbidity. So the thought of radiotherapy was also thought about because chemotherapy was also omitted because we anticipate that she may have poor tolerance to that. So radiotherapy was thought about because it offered a local definitive treatment option that could target all the known disease that we saw in imaging while avoiding the systemic toxicity of chemotherapy and surgery.
Great. And is there continued follow-up for this patient to this day?
There, there was continued follow-up for her. So it was durable control throughout the rest of her life. She ultimately did pass away from unrelated causes, but it was several years, and it couldn't, basically since publication of the report, there were another 4 to 6 months of just disease-free survival.
Great. Thanks so much for sharing. It sounds like the patient achieved an impressive long-term response following radiation treatment. So, what lessons does this case kind of provide to us about the potential role of definitive radiotherapy for patients who may not be candidate for surgery or systemic therapy based on their comorbidities?
So, one approach that came up was, we're thinking, how can we best help this patient? And in cases like this, where you're really concerned about quality of life at the end of the day for this patient who is medically inoperable, she was wheelchair bound, very bulky, but also symptomatic tumor. So it was lymphedema in the affected limb, plus it was just painful in the groin. We wanted to try and optimize both definitive local therapy, but also palliation. So strictly speaking, we prescribed 55 gray and 25 fractions to the tumor. So kind of following like an embrace to paradigm if you're thinking of like cervical cancer or just how you would boost nodes for endometrial cancer. But zooming out a little, when I was actually talking to the patient, I said, look, we want to try and help you feel better. I think there is an approach that we can do that's totally reasonable. And I had a similar difficult case in training where what we offered was a hemipelvic approach because it was only unilateral tendinopathy. This had been going on for years, so we thought the risk of a contralateral failure was low. So I said, look, I think we can treat you very safely. I think there's a chance we can even get a definitive dose, but we don't know how it's going to turn out. So let's just start treating you. And if at any point we have to stop, we'll have probably delivered at least a palliative dose. But if things are going well, we can just keep going till the end. And in theory, it's a definitive dose, and we'll do the follow-up and see if we're able to cure you. Ultimately, that's what ended up happening. But I like that degree of flexibility when you're talking to patients where you're not trying to force them into anything, and sometimes they're really nervous. You can say, let's just see how it goes. And I say 95% of the time, once they get that initial fear of just having to get radiation out of their system, they're like, oh yeah, this is going okay. Let's finish it and see it through to the end. And I'm glad it worked out.
Yeah, thanks so much for shedding light on that. Really meeting the patient where they're at is quite important in this field. Well, great. Any future directions that this project kind of sparked in the department?
Yeah, so I think in terms of future directions, really really understanding the fact that things doesn't always have to have a primary. It could, especially when it regards to treatment, diagnostically, this study really showed that it can encourage pathologist clinicians to consider the fact that benign malarian inclusions exist. As we noted in our case report, there's not a lot of studies that really talk about malarian inclusion, so that is one thing to consider. And also, since it was not a metastatic disease, if it really is arising locally within the lymph node, it really showed the therapies like definitive radiotherapy can really be reasonable and help, especially for cases like this where a patient is too frail for surgery or chemotherapy.
Yeah, I think Nneoma's point deserves emphasis also. In the case of endosalpingiosis, which is how this is presumed to have originated, where you have basically ectopic endometrial tissue, this isn't even a nodal metastasis. This is just a de novo tumor in the node. So when you're thinking about how to treat it, you might be influenced to think, okay, do we have to give more aggressive therapy like chemo if this spread to a node? When in fact, it didn't spread, it just arose there naturally. So I mean, this is such a rare tumor, it would be difficult to do. But the questions we would want to ask is, what is the typical natural history prognosis for this type of node-only disease? Does it support the fact that it arises from endosalpingiosis in the node as opposed to uh, a nodal metastasis? And look and see what the prognosis is and try and tailor the treatment accordingly.
Yeah, that all sounds like great and wonderful work in the making. And thank you so much for putting that out in the literature. So that was a great conversation. I'm so honored to have it with both of you. To wrap up for our listeners, a quick summary of this case. This case highlighted that even exceptionally rare presentations such as de novo nodal only Mullerian high-grade serous carcinoma of unknown primaries, definitive RT may offer durable disease control in carefully selected patients. Dr. Price and future Dr. Yu, thank you both for joining us and sharing your insights. And for listeners out there interested in learning more, you can read the full article and other recently published articles from CURiE research at acro.org/CURiE. Any final remarks from either one of you before we say our final goodbyes?
Well, first, I want to say thank you so much for inviting us to enjoy this podcast. I really appreciate the opportunity to talk about the research paper.
Yes,
Wonderful.
thank you
Thanks. Thanks for
again.
coming.
Thank you. And I'll highlight also just, how important Nneoma and I were discussing this before, how important multidisciplinary care is. As interesting the case is, and this is CURiE, our Radonc channel on Curious, the idea for radiation came from my gynonc colleague, Dr. Hernandez, who's a co-author on the paper. He said, Jeremy, what do you think about radiotherapy for this patient? I'm like, wait a minute, that makes total sense. So it just goes to show, you can always learn a lot from your colleagues.
For sure. Thanks to our listeners for listening to CURiE Conversations, and we'll see you next time. Thanks so much.
Thank you.
Thank you.